Good afternoon, everyone. Welcome to the masterclass session on giant cell arthritis, polymyalgia rheumatica, and vasculitis. I am Priyanka from Elsevier, and along with my colleague Shruti, we will be moderating the session today. Before we start, please note that all the attendees here are on mute by default. If there is any concern or if you have any question to ask from the speaker, then please write it only in the Q&A tab on your screen. We will try to address the maximum possible queries at the end of the session. Also, during the session, there will be a couple of interesting polling questions that will appear on your screen. The participation is anonymous and you will get around 30 seconds to submit your answer. So I hope to see you all participating in that. With this, I am pleased to introduce to you our esteemed speaker of today's session, Professor Stuart H. Ralston. Professor Ralston graduated from Glasgow University in 1978 and undertook postgraduate training in general medicine, endocrinology, and rheumatology. He has been professor of rheumatology at Edinburgh University since 2005 and was founding director of Edinburgh Clinical Trials Unit from 2009 to 2016. He is currently the clinical director of the rheumatology service of NHS Lothian and also the clinical lead for the osteoporosis service. Professor Ralston has researched widely on the pathogenesis and treatment of bone diseases and has contributed more than 300 publications to the world literature. He is involved in medicines regulation through his role as chair of the Commission on Humans Medicine, which advises the Medicines and Healthcare Products Regulatory Agency on matters relating to the safety and efficacy of medicines. He is Director-in-Chief of the scientific journal Calcified Tissue International. He has served on numerous editorial boards and is also an editor of Davidson's Principle and Practice of Medicine since its 21st edition. Welcome, Dr. Ralston. It is an honor for us to have you with us today. And I hand it over to you now.
Okay, thank you, Priyanka. Thank you to all at Elsevier. And thank you to the audience for joining me in this lecture on, as you've heard, giant cell arteritis, polymyalgia rheumatica, and systemic vasculitis. So just to go over the topics I'm going to cover, I'm going to start with giant cell arteritis, which we often shorten to GCA, then polymyalgia rheumatica, which we often shorten to PMR, and then I'll discuss large vessel vasculitis, including Takayashi's arteritis, and then ANCA positive and ANCA negative systemic vasculitis, and then finally Behcet's disease, which is a type of vasculitis that's ANCA negative, but I've just decided to deal with it separately. Now, starting off with giant cell arteritis, this is an uncommon condition, but which mainly affects older people. So the peak, if you look at the epidemiology, the peak incidence of GCA is about age 70 to 80. It's very rare below the ages of 50, and about 3/4 of patients are female. Now the prevalence varies quite a lot across the world. It's commonest in Northern Europeans, with a prevalence of 20 per 100,000 population. In Southern Europe, a little less common, 10 per 100,000. And in Africa and Asia, a little less common still, although it does occur. So I guess if you're practicing in India, you might see this less frequently than, for example, if you're practicing in the UK. Now, what causes this condition? Well, like many rheumatological conditions, there's a genetic predisposition. And I'm showing on this slide the results of a genome-wide association study, or GWAS, which was conducted in patients with GCA. And what you can see here is the chromosome number along the bottom, and on the vertical axis is the p-value. And really the strongest association by a long way is with HLA class 2 determinants, particularly HLA-DRB1, with a p-value of greater than 10 to the minus 50. So that's a very significant association. A couple of other genes also came up in this GWAS, P4HA2, which encodes proline hydroxylase, and plasminogen. So that's the genetic basis. What happens at a tissue level? Well, the key feature in GCA is an inflammatory infiltrate of the affected vessels, medium-sized vessels above the aortic arch typically. The vessels are infiltrated with Th1 and Th17 cells, so these are inflammatory T cells which release cytokines, and also macrophages and giant cells. Now, what you can see in an affected vessel is a narrowed lumen. Now, sometimes this completely occludes, which causes some of the symptoms. And I think you can see giant cells. This is a giant cell here, a giant cell there, a giant cell there, a giant cell there. And that gives the condition its name of giant cell arteritis. If we turn to the clinical presentation, almost always patients will present with a headache. This is typically in the temporal region. It can be one side or on both sides, but you can get headache in other parts of the skull. You may see temporal artery swelling and tenderness, and in fact in this clinical photograph there is quite obvious thickening and swelling of the temporal artery, but often those signs aren't present. Accompanying GCA, it's quite common to get pelvic and shoulder girdle pain and stiffness, and we call that a polymyalgia rheumatica type syndrome. And as I'll show in subsequent slides, there's a very close relationship between GCA and PMR. A dreaded complication of GCA is visual disturbance. This can present with diplopia or blurring and sometimes complete visual loss, which if it occurs is irreversible. So it's important, if you suspect the diagnosis of GCA, then you really do something about it pretty quickly. Another common symptom is jaw claudication. That's pain in the jaw when the patient is chewing, and also systemic symptoms like malaise, fever, just generally feeling unwell. Now, what about the diagnosis? Well, the key to the diagnosis really is in the clinical history, possibly with some signs on examination. If you check bloods, almost always the ESR and C-reactive protein are raised, often quite markedly raised. There may be a mild normochromic normocytic anemia. If you check for autoantibodies like rheumatoid factor, anti-nuclear antibody, these are typically negative. So GCA is not associated with autoantibodies. There have been other ways of confirming the diagnosis are through temporal artery biopsy. So a portion of the temporal artery is taken at surgery. So that's a good diagnostic technique. It is specificity of 100%. So if you pick up arteritis, then obviously you've clinched the diagnosis. Although the sensitivity isn't so great. I'm taking here data from a study called the Taboo study, which was performed in the UK, and they reckoned that the sensitivity of temporal arteritis, temporal artery biopsy, was only about 39%. So what that means is, if your biopsy is negative, it doesn't help you. You could still have the diagnosis. There's been increasing interest in ultrasound of the temporal arteries, again as a diagnostic technique. The specificity is about 80%. Not quite as good as temporal artery biopsy, but sensitivity a little better than temporal artery biopsy, but again, it's only picking up half of the cases. So even though you may have a negative ultrasound, you can still have the diagnosis. So it really is a clinical diagnosis. And the thing that clinches it is if you have a symptomatic response to steroid treatment, usually within 3 to 4 days. And I'll come to treatment shortly. On the right-hand part of the slide, I've shown an example of an ultrasound scan in temporal arteritis. This is a Doppler ultrasound. What you can see is the red area is blood flow through the temporal artery, and this black area surrounding the red area is actually representative of the thickened vessel wall. So they call that the halo sign on ultrasound. Okay, moving on to management. Well, corticosteroids are really the mainstay of management. You need high dose steroids. Usually we're giving between 40 and 60 milligrams of prednisolone a day. often continuing that for 2 to 4 weeks and then gradually reducing by 10 milligram a month. And then when you get down to 10 milligrams, reducing very slowly by 1 milligram per month. Now, if you cannot get the steroid dose down, often steroid-sparing medicines are used. One is tocilizumab, which I'll discuss shortly. The others include things like methotrexate and azathioprine. If you have a patient with GCA, these are an older population, you're giving steroids, so often osteoporosis prophylaxis needs to be given. And also you need to consider vascular risk factors like managing high cholesterol, possibly low-dose aspirin. I want to take you through this slide here. It's a so-called GIACTA study. And what the investigators did here is they randomized patients to corticosteroids and placebo, or corticosteroids and tocilizumab. Now, tocilizumab is a blocker of interleukin-6 signaling. And in the two groups, the patients could be randomized either to have a fast reduction in steroid dose or a slow reduction in steroid dose. And what we're looking at on the vertical axis is the patients who are free of relapse. Now, what you can see is in the placebo group, if there was a fast reduction in steroids, then the condition often relapsed. This is going up to 1 year. There was maybe only about 30% of patients who didn't relapse. With a slow reduction of steroids, it's a bit better. That's what it's about 40 or 50% with a slow reduction. So this emphasizes the importance of slowly reducing steroids in this condition, because otherwise you can get a flare up once again. With the tocilizumab arm, then it didn't matter whether you were a fast steroid reducer or a slow steroid reducer. There was much less of a risk of relapse in patients on tocilizumab. And so tocilizumab, especially if someone is at risk of steroid-induced side effects like diabetes, then this is a good option to reduce the risk of relapse, certainly within the first year of treatment. Now, what about the patient with GCA? What do you do with them? Well, usually patients need to be monitored for recurrence of symptoms. That is accompanied by checking inflammatory markers, ESR and CRP. And if you have a flare-up again, you may need to increase the steroid dose, and especially if the inflammatory markers rise. Excuse me. However, it's important you don't simply treat a raised ESR and CRP, because this elderly population, things like a urinary tract infection or chest infection can occur. And of course, the last thing you want to be doing is treating a chest infection with high-dose steroids. My rule of thumb for instituting long-term immunosuppressive medication is if you cannot get the prednisolone dose below 10 milligrams daily, and in that case, I usually go for azathioprine or methotrexate. There isn't much experience in using tocilizumab long-term, but as the data emerges from clinical trials of that drug, it could be we may be using it more in the future. Okay, so that's giant cell arteritis, very straightforward. What about polymyalgia rheumatica? Well, as I've mentioned, it's related to GCA. It's about 3 times more common, but there is a clinical overlap with GCA. And I say that because if you take patients with GCA, about half of them will have polymyalgic type symptoms. Conversely, if you take patients with PMR that present with proximal muscle pain and stiffness, eventually about 15% of them will go on to develop GCA. So really, these are different ends of the spectrum of what I would consider to be the same disease. The peak incidence, like GCA, age 70 to 80, rare below the age of 50, and most patients are female. So these are kind of very much the same disease. Now, if we turn to the pathophysiology, this is less well understood than GCA. There is a genetic predisposition. There's been candidate gene studies showing association with the HLA class 2 region, exactly as in GCA. I've mentioned there's overlap with GCA in people with symptoms of headache and vasculitis. In the peripheral blood, there are increased Th17 cells, so that ties in with GCA, where you get Th17 activation. And there have been a few studies looking using PET to look at the affected tissues, and I'm showing here a PET scan. This isn't something we do routinely in clinical practice, but it's a research technique. So looking at the shoulder girdle, what you can see is uptake of fluorodeoxyglucose in the shoulders and also in the pelvic girdle. And this perhaps explains why you get the typical pain and stiffness in the shoulders and pelvic girdle with GCA. So it's a bursitis. And that just goes some way to explaining why you get the symptoms you do in this condition. Now, turning to the diagnosis, very much is a clinical diagnosis. So the clinical history is proximal muscle pain and stiffness, typically affecting the shoulders and the thighs or the buttocks. The ESR and CRP are usually raised, as in GCA. There's often a mild anemia, as in GCA. As in GCA, the autoantibodies are negative. Importantly, muscle enzymes are normal, so there's no elevation in CK. So if you had a raised muscle enzyme, that would be more consistent with a myositis, but those are normal in PMR. And if you treat someone with PMR with steroids, then usually the symptoms resolve within about 3 or 4 days. And this little cartoon shows a typical patient. If you've got the diagnosis right, you start the patient in steroids, you see them 3 or 4 days later, and they say, "Doctor, thank goodness, I'm absolutely cured." So if the patient says that, you know you've got the diagnosis right, and it's a very gratifying thing to have as a doctor treating this condition. So management, I mentioned that steroid response really gives you part of the diagnosis. In PMR, we use lower doses of steroids, typically 15 to 20 milligrams a day. We reduce by 5 milligrams a month. When at 10 milligrams, reduce by 1 milligram a month. And we're using steroid-sparing medicines if you can't get the dose down below 10 milligrams. And again, because these patients are elderly at risk of osteoporosis prophylaxis is something you may need to consider. So that's polymyalgia rheumatica. It's usually a quite easy diagnosis, but of course you've got to maintain, sorry, I'll just go back. You've got to maintain an index of suspicion. Now, I'll turn now to large vessel vasculitis and Takayasu's vasculitis. So Takayasu's affects the branches of the aorta. You can also get large vessel vasculitis affecting lower down in the aorta, the femoral arteries, and probably these are part of the same disease spectrum. The cause is not known. One suspects it's kind of similar in many respects to GCA. Most patients are female. Again, you may see systemic features and abdominal pain related to narrowing of the vessels in the abdomen, and you may have symptoms related to vascular insufficiency and aneurysms. So you get claudication in the arms, for example, or stroke or whatever. Now, the diagnosis of large vessel vasculitis, it may be picked up on clinical examination when you might see a difference in blood pressure between arms. You might have absent or diminished pulses in one arm versus the other. Typically, the CRP and ESR are raised, in other words, an acute phase response. You may see a mild anemia. So this is all very similar to GCA. Like GCA, autoantibodies like rheumatoid, anti-nuclear factor are negative. The pivotal thing in making the diagnosis of large vessel vasculitis is vascular imaging. And you can use things like CT angiogram. So this is a CT, now this is an MR angiogram showing blockage of the subclavian artery in a patient with Takayasu's. And this is a PET CT scan. So it's a transverse section of the abdomen. And you can see the increased uptake of fluorodeoxyglucose in the aorta. And so that is often the clinching diagnosis when you have vascular imaging. Now, management is very much similar to GCA, high-dose steroids, gradually reducing with steroid-sparing medicines. Tocilizumab is often used, although it's unlicensed for this indication, hasn't been really trialed, but of course, large vessel vasculitis is a rare condition. And again, we may use immunosuppressive drugs like methotrexate, azathioprine, and mycophenolate. Like GCA, in older individuals, you've got to consider osteoporosis prophylaxis and managing vascular risk factors. Okay, so far so good. That's large vessel vasculitis. I'd now like to go on to discuss systemic vasculitis. Now, there's a whole bunch of conditions. There's various classifications that can be used, the so-called Chapel Hill classification. I think what a useful classification is this classification, which is a functional classification. And it divides people up depending on whether they're anti-neutrophil cytoplasmic antibody positive or ANCA positive or ANCA negative. Under the ANCA positive group, we've got granulomatosis with polyangiitis, GPA as we call it nowadays, used to be known as Wegener's granulomatosis. You've got microscopic polyangiitis, or MPA, and then you've got eosinophilic granulomatosis with polyangiitis, or EGPA, apologies for the typo, and that's Churg-Strauss syndrome. Then you've got the ANCA negative types. That would be polyarteritis nodosa, cryoglobulinic vasculitis, and Behcet's disease. So let's start with the epidemiology. This is all of these types of vasculitis considered together. These are rare conditions, okay? The gender distribution is equal for most forms of vasculitis. The systemic vasculitis tends to affect an older age group, age 15 to 80 years, although with Behcet's, it's quite different. That affects younger people, at least starts in younger people, often by the age of 20 to 30. If we look at the incidence or the prevalence, of ANCA positive vasculitides, they really are rare. So GPA 10 in a million, MPA 8 in a million, eGPA 3 in a million. Similar story with the ANCA negative vasculitides, PAN, depending on the study you read, between 2 and 8 per million, cryoglobulinic 1 per million. Behcet's, though, has a huge variation in incidence, between 1 and 100 per 100,000. And this is largely determined by geography. So Behcet's is quite common in countries of the Middle East, particularly Turkey, Iran, but in Britain, for example, it's much less common. In India, it would be much less common. And that's because there's a genetic predisposition to this condition, as I will discuss later. So turning to the pathophysiology of ANCA positive vasculitis. Well, like GCA, there's a genetic predisposition, although it's a different, it's a class 2 determinant, but it's HLA-DQ. And here I'm showing the results of a genome-wide association scan for ANCA positive vasculitis, and a very significant p-value, p 10 to minus 35, for the HLA-DQ region. So it's immunologically determined. If we look at a tissue level, the characteristic features are vasculitis with granulomas. Those can affect the nasal passages, the upper lobes of the lungs, and the kidneys. If you have EGPA, there's an eosinophilic infiltrate if you take a tissue biopsy, and often a systemic eosinophilia. In MPA, there's a widespread small vessel vasculitis without necessarily much in the way of granulomas. Now, with regard to the pathophysiology, there's probably a predisposing environmental factor which triggers the disease if you're genetically predisposed. What we know is, or what has been shown, is that if you infuse autoantibodies, ANCA autoantibodies, to preclinical models like mice, there is, these can reproduce the disease, indicating that the antibodies are themselves pathogenic. Okay, let's go to the clinical presentation. Now, with vasculitis, this is ANCA positive vasculitis, but pretty much with all forms of vasculitis, it's a multi-system disease. And if you have a patient with involvement of many systems, then vasculitis is one of the things you need to think about. A bit like SLE, it can also affect multiple systems. So the patient may experience myalgia, arthralgia, feeling generally unwell. There may be cutaneous vasculitis, as shown here. There may be mononeuritis multiplex. So what I'm talking about there is foot drop due to, for example, involvement of a nerve. If there's GPA, you can often have nasal symptoms, nasal crusting, bleeding, orbital mass. Here's a patient with GPA with an orbital mass shown here. If the lungs are affected, you may have dyspnea and hemoptysis. If you have eGPA, that's Churg-Strauss, you may have difficult to control asthma. And with GPA and MPA and indeed eGPA, you can have renal involvement with hematuria, proteinuria, and if untreated, renal failure. So the diagnosis, first of all, you've got a clinical picture of multi-system involvement, possibly with some of the signs that I've shown you. You typically will have a raised ESR and CRP. On a blood count, you may see eosinophilia in Churg-Strauss, that's eGPA. You may see renal impairment if there is renal involvement. The key diagnostic tests, well, there are two key diagnostic tests. One is ANCA, anti-neutrophil cytoplasmic antibodies, which divide into two groups, anti-MPO, which is myeloperoxidase, which is perinuclear staining, as shown here, and anti-PR3, which is anti-proteinase 3, which is cytoplasmic staining, shown there. A tissue biopsy might might be needed sometimes. If you do that, you will see evidence of a vasculitis as shown here. Sometimes if you do a chest x-ray, you might see in GPA an upper lobe infiltrate or evidence of pulmonary fibrosis. So how do you manage ANCA positive vasculitis? Well, the management of vasculitis is pretty similar with most types. High dose steroids are commonly used, 60 to 80 milligrams, sometimes pulse methylprednisolone, and that is combined with cyclophosphamide or rituximab. And there have been trials comparing steroids plus cyclophosphamide versus steroids plus rituximab, and they haven't shown a very big difference between the two treatment arms. A recent treatment which has emerged is this drug, mepolizumab, which is an antibody to IL-5, and it has been shown to reduce the risk of relapse in EGPA. So that's Churg-Strauss syndrome. So this is the risk of relapse in the vertical axis. This is time. And what you can see is in this trial, the relapse up to 90% in placebo-treated patients with steroids plus placebo, where in mepolizumab it was greatly reduced to about 50%. So this looks to be a very useful treatment option for EGPA. In the longer term, like the other types of vasculitis, you try and gradually reduce the steroids. You transition to another immunosuppressive if you were on cyclophosphamide, or if you've been treated with rituximab, often patients will have pulse rituximab at intervals after the initial diagnosis to maintain the disease control. So longer term follow-up, you need to keep these patients under review. Usually, almost always, you need to maintain immunosuppression because patients that can relapse several years after the initial diagnosis. If you can withdraw steroids, that's great, but if you can't, you may need to consider bone protection, as in the other conditions I've discussed. So let's move on to an ANCA negative type of vasculitis, that's polyarteritis nodosa. The classic feature here is vasculitis and aneurysms of medium-sized vessels. Like the other types of vasculitis, there's a diverse presentation: abdominal pain, a neuropathy, skin nodules, vasculitic rash, myalgia, arthralgia, generally feeling unwell. Myocardial infarction can occur, hematuria can occur if there's kidney involvement. And in some cases, PAN is associated with chronic hepatitis B infection. And if it is, the condition can be helped by treating the hepatitis B. So if we look at the diagnosis, you've got the clinical picture, raised ASR and CRP. The ANCA will be negative. What can often clinch the diagnosis is an angiogram, and this is a patient that presented to my clinic with PAN, and I think you can just see the little microaneurysms in the renal vessels, which clinch the diagnosis. If you don't see that, a tissue biopsy may be necessary, and very important to check for hepatitis B, because if that's positive, treatment can help with the vasculitis. So management, pretty much the same as ANCA positive, high dose steroids and cyclophosphamide. I should say rituximab hasn't been tested in PAN, so we're not sure if that works. So usually people will give steroids and cyclophosphamide. Plasma exchange has been used with success. If there's hepatitis B, that should be treated with the usual drugs. Longer term, as in the other forms of vasculitis, try and reduce steroids and transition to azathioprine or methotrexate. Winding up, or almost winding up, with cryoglobulin-emic vasculitis. So what is this? This is due to immune complex deposition in blood vessels, and that stimulates an inflammatory reaction. There's various underlying causes, things like myeloma and Waldenstrom's macroglobulinemia, where you get a lot of immunoglobulins being produced and they can deposit in the vessels. Chronic inflammatory disease, again, you have hyperglobulinemia, and hepatitis C infection, where you have antibody production. So the management of this is to treat the underlying condition if possible, but if that doesn't work, steroids and immunosuppressive therapy, rituximab is sometimes used, hasn't been looked at in randomized trials, but pretty similar really to the other forms of vasculitis we've discussed. So winding up to the last form of vasculitis to discuss today is Behcet's disease. I've mentioned already it's most common in people of Middle Eastern descent. Worldwide, the highest incidence in the world is in Turkey. There's a genetic association with HLA and specifically HLA-B21. Now, the clinical presentation, as in the other conditions, is quite varied. A key feature, in fact, an almost invariable feature, is oral and genital ulcers. You may get uveitis, you may get pustular skin lesions, erythema nodosum, arthritis and arthralgia, venous thrombosis, and neurological involvement due to arterial thrombosis in the CNS. So it is a clinical diagnosis first and foremost. There almost always is there oral or genital ulceration. Here's a picture of oral ulceration in someone with Behcet's. Autoantibodies are negative. If you have acute disease, raised ESR and CRP are usually raised. There's a test called the pathergy test in which you develop a pustule at a site of needle puncture. So this is a patient that's had the needle puncture the skin, and you can see this little red area, this little pustule, and that can help lend support to your diagnosis. You may need imaging if you have CNS involvement, and that may show evidence of venous thrombosis or cerebral vasculitis or infarction. So Behcet's, it's a matter of putting all these signs and symptoms together and coming to the diagnosis. Now, management, well, topical steroids and or colchicine are the first line for oral and genital ulcers, and in many cases that's all you need. If the condition is associated with systemic vasculitis, then you might need to give systemic steroids and immunosuppressive therapy, very much as described for the other forms of vasculitis. You certainly need that if you've got uveitis, because there's a danger of blindness. Biologics have been tried in Behcet's, and anti-TNF has been found to be useful for resistant patients, and other forms of biologics are being trialed also, but without conclusive results yet. So if I can summarize the key points of vasculitis, these are rare conditions, but important not to miss, because if you get the diagnosis wrong or miss the diagnosis, they can be fatal, or you can get a severe complication like blindness. They have an immunological basis related to genetic variation in class 1, that's Behcet's, or class 2 genes, that's GCA and ANCA positive vasculitis. As I mentioned, the presentation is with multi-system involvement. And if you have someone with multi-system involvement, then you must always be thinking about vasculitis. Diagnosis is usually based on the clinical picture, evidence of inflammation, often supported by tissue biopsy and imaging. And as I mentioned, the treatment pretty much for all forms of vasculitis are high-dose steroids and immunosuppressives. So that's a quick run through vasculitis. And what I'd like to do now is give you a case scenario. So this is a case scenario which will test some of your knowledge, which you probably already have, but you may have learned during the course of today's presentation. And I'll go through the case history. And it's a 58-year-old woman who was referred to the rheumatology clinic, and she was complaining, in her own words, of generalized aches and pains. Okay. So she had pain and stiffness affecting the shoulders, neck, hands, wrists, and thighs. She complained that her symptoms had been gradually worsening over the prior 3 months. She had a couple of chest infections, didn't think too much of them. They'd been treated successfully with antibiotics. And the past medical history was pretty unremarkable. She was on anti-acid medication, she was taking citalopram, and she was taking naproxen as an anti-inflammatory. On examination, there wasn't very much to find. Although she had muscle pain and stiffness, her muscle power and tone were normal. She didn't have any tender spots on the back or arms or legs. She didn't have any synovitis, nor did she have any evidence of osteoarthritis. Chest and cardiovascular system exams were normal. There was no neurological signs and no skin rash. Now I'm showing you the results of the initial investigations. Now what you can see here is there's a mild anemia. Her white cell count was a little bit elevated. Her platelets were elevated. Her ESR was most definitely elevated at 105. Biochemistry was unremarkable, except the C-reactive protein was elevated. And the chest X-ray on initial presentation was unremarkable. On immunology screen, she had a weakly positive ANA at 1 in 80. Her CCP antibody or ACPA antibody was negative, but her thyroid peroxidase antibody was quite elevated, although in fact she didn't have a history of thyroid disease and her thyroid function tests were normal. So what I'm going to ask the audience, what do you think at this point is the most likely diagnosis? Is it fibromyalgia, Is it polymyalgia rheumatica? Is it lupus? Is it myositis? Or is it vasculitis? And I'll give you a few moments to vote. Okay, do we have the votes coming in? Yes. Okay, thank you very much. So we have 5% fibromyalgia. The majority vote is for polymyalgia. A few people say lupus. Almost no one says myositis. And a few people say vasculitis. Okay, thank you very much. Well, what we thought at that time was the diagnosis was polymyalgia rheumatica. So it very much goes with the majority vote. Really because she had proximal muscle pain and stiffness, she was the right age group, she had a raised ESR and a raised CRP and a mild anemia. So all of those would fit with polymyalgia rheumatica. So what we did was we started her in prednisolone 15 mg daily, as is usual in PMR. She was complaining of a persistent cough, so we ordered a chest x-ray once again, and we reviewed her after 5 days. Now, if someone has polymyalgia rheumatica, I like to review the patient after maybe a week or slightly less than a week to see if their symptoms had responded. Now, she reported that her symptoms were a little bit better on steroids. However, the objective response was a bit disappointing. The ESR had fallen to 102, but that's not very much, 110 to 102. CRP had fallen, though, quite a bit, from 206 to 95. And I'll just show you the result of the chest x-ray, which we performed after the second, in between the first and the second clinic visit. Now, what would you do now? Here's your second question. So we thought it was polymyalgia rheumatica. We've given her steroids. She's responded a bit. Would you increase the steroid dose? Would you request a muscle biopsy, maybe thinking that PMR wasn't the right diagnosis? Would you repeat the ANA and ACPA antibodies? Would you check ANCA in case of a vasculitis? Or would you add a steroid-sparing drug, such as methotrexate? So, again, you have the choice of 5 options, and we'll just wait 30 seconds or so while the votes are coming in. Interesting. Okay, some people would increase the steroids, some would do a muscle biopsy, some would do ANCA, some would repeat ANA, some would check ANCA, some would add methotrexate. Well, very interesting. I'll tell you what we did. We checked the ANCA, okay? And the reason for that was, although she didn't respond completely, I would have expected a better response on 15 milligrams of prednisolone to this. I didn't see any reason to do a muscle biopsy because it wasn't really a history consistent with myositis. There was no muscle weakness. There'd be no point in repeating the ANA and CCP because they'd only been done like a month before. And I think that my feeling was to give methotrexate probably wasn't going to be helpful at this point. So we checked her ANCA, and in fact, part of the reason for that was when you look carefully at the chest x-ray, I think you can see there's a little bit of an infiltrate in the right upper lobe of the lung. So that was yet another reason for going for the ANCA, because I was worried that this may actually be a vasculitis. So the additional investigations, hemoglobin, again, the anemia, raised ESR again, CRP had fallen a bit. Her complement, which we also checked, was normal, but the MPO ANCA was quite significantly elevated at 25.3. The normal in our lab is less than 5. The PR3 ANCA, however, was completely normal. So, what do you think is the likely diagnosis now? So here's your third quiz of today. Is it fibromyalgia? Is it polymyalgia rheumatica? Is it lupus? Is it myositis? Or do you think it's vasculitis? So we can have the poll. And we'll wait again another 30 seconds. I hope you're all going to get this right now. Well, 76% say vasculitis. We've got 10% PMR, 5% fibromyalgia, 6% lupus, 2% myositis. Well, you're a very good audience. You're quite right. The likely diagnosis is vasculitis. And actually, it's consistent with the presentation of GPA, or granulomatosis with polyangiitis. She's got an acute phase response, raised ESR, raised CRP. There's a pulmonary infiltrate. There's the MPO ANCA, which really is the clinching thing that makes you think of GPA. That's positive in about 80% of people with GPA. So as I mentioned in the lecture, it's an autoimmune disease. You get vasculitic damage to the upper airways, nasal passages, and kidneys. Although in her case, it was very much only the upper part of the lung. Although we probably made the diagnosis quite early in the course of the disease, and it could be if time had gone on, she may have developed hemoptysis and so on and so forth. It was quite striking that systemic symptoms were the most prominent in this lady. She had myalgia. She really did have a polymyalgic presentation, which you can see sometimes, but it looked like the underlying diagnosis was ANCA positive vasculitis. And I've mentioned she had an abnormal chest X-ray. Her urine was clear, so there was no renal involvement. So what we did is we did a high resolution CT, which confirmed an upper lobe infiltrate. We did a CT of the nasal passages and orbits. That was fine. Urine dipstick was fine. Renal function was normal. We increased our dose of prednisolone to 30 mg daily. We commenced cotrimoxazole because we were just about to start rituximab, and we treated her with rituximab. The reason for giving cotrimoxazole is that she was on high-dose steroids and rituximab, so that's as prophylaxis against pneumocystis pneumonia. And I saw her actually at the clinic recently, about a month ago. She was doing pretty well. ESR and CRP were normal. We'd managed to get the prednisolone dose down to 3 milligrams daily. And in fact, her DEXA scan was completely normal, so we didn't need to give any bone protection. And so there we have it. It's quite an unusual one, but it's an ANCA positive vasculitis presenting as PMR. The clues to the diagnosis were the incomplete response to prednisolone, the fact that inflammatory markers really weren't suppressed very well. There was a bit of shadowing chest X-ray. There was something in the way of respiratory symptoms. And currently, I'm happy to say the patient is clinically well and stable on follow-up, although no doubt I may need to give her rituximab again in the future. So that's the lecture and the case scenario finished. Just like to wind up with reminding you that all of the information I've given today is very clearly dealt with in Davidson's Principle and Practice of Medicine, the rheumatology chapter, of which I am an author. And I urge you to go out and buy that book if you don't already have it. Okay, so I think there will be some questions or time for questions from the audience, and I can just see
Yes.
the question.
Thank you, Professor Ralston, for taking up this interesting session for the students. So you can see the questions from the students in the Q&A tab.
Okay, I can indeed. Is
Yes.
GCA associated with neurological problems? Trigeminal neuralgia? Not particularly is the answer to that. Thank you, Galaxy M21. Obviously, you can get headache, but it doesn't usually cause trigeminal neuralgia, and in fact, it doesn't usually cause a neuropathy. Bicky says, will initiation of steroids alter the biopsy finding? Yes, the answer to that is. It's reckoned, though, that as long as you get the biopsy within a couple of weeks, then there still are going to be pathological changes. You asked also, what is the minimum size of the biopsy? I mean, people say at least a centimetre. The thing with the biopsy in GCA is there are what's called skip lesions. So in other words, it may affect one part of the artery, then the next part may be normal, and then a third part may be abnormal. So I think 1 centimetre, some people do 2 biopsies, depending on where you are. So as long as you do the biopsy within 2 weeks, you could still make a diagnosis. Thanks for that question. Now, someone has asked, what investigations do you do in the primary stage? I'm not sure what that concerns. Is that GCA, or maybe you could type that again, because I'm not sure what you're asking. Here's one. Why is steroid sparing not used as first-line treatment? Well, the answer is that you can often get a very good therapeutic response to steroids, and it's only really the risk of steroids is long-term high dose. So side effects with steroids are dependent on dose and duration of therapy. So there are some patients, they respond pretty well, let's say to GCA, 15 milligrams, you get down to 10, you get down to 5, and they're off steroids like by 1 year. And in that case, there's not too much of a problem. Where the problem is that if you have long-term symptoms and you're on more than 10 milligrams for more than a year. So that's why we tend to give the steroid sparers later on. Remember that these immunosuppressive also have adverse effects, and so it's a risk-benefit balance basically in doing it, and it has to be done on a case-by-case basis. What's the significance of ESE? Sorry, I don't know what that acronym stands for. I'll have to skip that one. Abel Raju, GCA and temporal arteritis. I mean, GCA and temporal arteritis are the same, basically. It's a different name for the same thing. GCA often affects the temporal arteries, but not always. It can affect the vessels at the back of the neck, and it can affect the axillary vessels. So they're both, it's the same, it's a different name for the same thing, basically. Thank you very much. Other than steroids, what regime could you use in patients who are poor? Thank you for that question. Well, obviously steroids are inexpensive treatments. Those are easy to give. Tocilizumab, though, I can well understand is quite an expensive treatment. But I think if the patient needs steroid sparing, methotrexate, azathioprine are inexpensive drugs, and you could certainly use those. Now, Akanksha Singh says, why are females more commonly affected? The answer to that is we really do not know. We know that on one hand, estrogens can affect the immune system, but it's usually postmenopausal women that are affected. So really, I have to say, there's not a good answer to that. It's a bit like, why are men more affected by COVID? We don't really know the answer to that either. So it's just one of those things that is unclear, and a very important topic for future research. Okay, someone's mentioned about Takayasu's. Well, high-dose steroids are the first line. There haven't been comparisons of things like methotrexate or tocilizumab, so you can't say which treatment is more potent, but steroids are first line, and then if you don't get an adequate response to that, then you need to come in with some immunosuppressives. Can you use a duplex scan? Yes, certainly that would be possible. I think that probably MRI angiography, CT angiography is maybe better, but they haven't been directly compared. Now, let me just see. I'll go through. Okay, so here's a question. When do you suspect vasculitis? Because if people come along with fatigue and bone pain, and it's quite a non-specific diagnosis. Yeah, I suppose that's the thing about clinical medicine. You have to take everything into account. If you had fatigue and bone pain and malaise, but there was no abnormalities of the ESR or the CRP, then obviously that would be weighing you against an inflammatory condition like vasculitis. If, on the other hand, you have those symptoms and there is evidence of raised ESR and CRP, then that's when you kind of start thinking, well, this could be vasculitis, and then do some other investigations to confirm it. Okay. Yeah, why do you care about osteoporosis prophylaxis in PMR? It's mainly due to the steroids, actually. Thank you for that question. So steroids are a very important predisposing factor for osteoporosis. They inhibit bone formation, and so really, and it's an older group of people anyway who are at risk of osteoporosis. So that's why, that's why you're worried about osteoporosis in this population. Obviously, young people also need steroids, but the risks of osteoporosis are less in younger individuals. Okay. HLA. Yeah, you're quite right. HLA is involved in many of these diseases, as indeed in rheumatoid and things like psoriatic arthritis. I think we're a long while off gene therapy. What people are considering in certainly some forms of inflammatory arthritis is trying to induce tolerance. If we knew the antigen, unfortunately, we don't know the antigen in many cases. So I don't think gene therapy is a prospect in the near future, but trying to induce tolerance is something that rheumatologists are looking at, mainly, admittedly, in inflammatory arthritis. The association between polyarteritis and hepatitis B, well, there is a clinical association. The cause is not entirely clear. Obviously, if you have hepatitis B, there's an immune response going on. There may be cross-reaction between the immune response to the hepatitis and antigens or determinants in the vessel wall. And that's really the best explanation I can think of. It's rather poorly understood. Whereas as I mentioned, in cryoglobulonemic vasculitis, interestingly, it's hepatitis C that's associated with. So I guess there may be cross reaction. The pathology test in Behcet's, well, no one really knows the pathophysiology. There's infiltration of the tissue with neutrophils. So obviously something going on with neutrophils in Behcet's, but what exactly triggers that is unclear. And let me see. Henoch-Schönlein purpura. That's an interesting one. Yeah, Henoch-Schönlein is mainly affects younger people, as it did in your own case. And then you may have had a reaction to the vaccine. That's quite interesting. I hope the purpura didn't come back, though. HSP, though, is usually a self-limiting condition, which doesn't often require treatment, but hepatitis V vaccine, I've not heard that causing HSP or vasculitis with the Hep B vaccine, but anything can occur. Now, someone else asks, was there ANCA positivity? Yes, the patient was positive for ANCA. It was, I think if you remember the case scenario, the ANCA titer was about 25, so she was positive. I can't remember the questions now, so I can't answer that. Right, someone asked, what's the prognosis of vasculitis without treatment? Well, if you have systemic vasculitis without treatment, I mean, these diseases are pretty uniformly fatal with renal involvement, and so really treatment needs to be given. So they have a very bad prognosis without treatment. In the case of GCA, then obviously visual loss is a real worry. So you need to pick up these diseases and need to treat them. Someone asked, what's the use of the DEXA scan? So if you've got someone on high-dose steroids, DEXA scan can be useful in directing therapy. Currently, if someone's on more than prednisolone, 7.5 mg for more than 3 months, and the T-score on DEXA is less than minus 1.5, that's when we advise bisphosphonate treatment or some kind of bone-sparing treatment. Someone asked, what's the view of the recently made COVID vaccine in Russia? Well, I'm not an expert on this, but I'm not aware of clinical trials in it, and I would probably be wary about it. Someone asked size of temporal artery biopsy for GC. I think I've mentioned that, at least a centimeter, maybe 2 centimeters. SLE, I think that's beyond the scope of the present of the current presentation. But like vasculitis, SLE, multi-system disorder, I think what can happen then, though, you're looking for a positive ANA or a positive double-stranded DNA. Now, someone asks, why was the ANA positive? Well, what you find is that in older people especially, it's quite common to get a weakly positive ANA, like 1 in 80, 1 in 40, and 1 in 80, and it's not really of any clinical significance. So what is more significant is if the anti-double-stranded DNA is positive. So in that case, the positive ANA, I did not think was clinically significant. And in fact, as it turned out, the patient was positive for ANCA. Why shouldn't GCA respond to steroids? Well, I think in the case I showed, there was a little bit of a response to steroids, but if you have vasculitis, you need much bigger doses of steroids than in PMR. Okay, you're talking about 40 to 60 milligrams of steroids, plus you need a more powerful immunosuppression. So PMR will usually respond pretty completely to a lowish dose of steroids, 15 to 20 milligrams. So the fact that she didn't respond, that kind of raised the possibility that it was another diagnosis. And in fact, it turned out to be vasculitis. Now, someone quests Churg-Strauss. Well, Churg-Strauss, typically you will have an eosinophilia in that condition, okay? And you may have difficult to treat asthma. So because of the lack of eosinophilia and the other features, I felt that GPA was the most likely diagnosis. Although, as it turns out, the treatment of the two conditions would be quite similar. Okay, if you're treating vasculitis, how much does the dose of steroids be increased? Someone asks. Well, if you have, like I say, if you've got GCA or systemic vasculitis, you're starting off with a high dose, 40 to 60 milligrams. If it's PMR, you're starting off with a much lower dose, maybe 15 milligrams. And the fact in the case I showed that the patient didn't really respond to the lowest dose made me think of another diagnosis. Okay, I'm just going through the questions. We're getting close to the finish of the session. We've got another 5 minutes. What's the differentiating factor? Well, ANCA is the differentiating factor, because otherwise one type of vasculitis can look like another vasculitis because you get multi-system involvement, you get often overlapping symptoms. So the ANCA provides the clue. And if you're ANCA positive, it means it's been shown that that type of vasculitis responds to rituximab. So that's one of the reasons for using ANCA and making that diagnosis. Now, someone's asking about renal disease. Well, if you're renal involvement, I mean, the management is not any different from treating systemic vasculitis anyway. High dose steroids, immunosuppressives. Obviously, if the condition has caused renal damage and renal impairment, then the patient may need dialysis. But we're hoping to pick up patients and treat them before that occurs. Someone's asking about neurological symptoms in Behcet's. Well, they're quite diverse. You can get cerebral venous thrombosis, you can get stroke, you can get transverse myelitis. It just really depends where the vasculitis is. Okay, I've answered that. I think we've got 3 minutes more. I'll maybe answer one more question. How do you differentiate vasculitis and SLE? Well, this is where your ANA and anti-double-stranded DNA antibody would be important. Okay, because otherwise the conditions can present quite similarly. But in systemic vasculitis, unless it's PAN or cryoglobulinic or Behcet's, you would be positive for ANCA. In SLE, you would be positive for ANA and double-stranded DNA. Now, Behcet's is quite a tricky one to differentiate from SLE, but ANA and anti-double-stranded DNA would be typically negative in Behcet's. But otherwise, it can be confused because of the mouth ulcers and genital ulcers. So those can be mixed up with one another, but I think the immunology will give you the answer. Okay, I think we'd better wind up there. I'm sorry, there's a whole screen of questions. I'm sorry I wasn't able to answer all of them, but it's about 29 minutes past 1, well, UK time, and we've done about an hour. So I hope that was useful, and thank you for your attention.
Thank you, Professor Ralston. Thank you very much for this session today. I can still see the questions coming in from the attendees. So maybe I will just send you the list of all these questions to you after the session, and you can have a look later on. So
Yeah,
with this,
thank
I would
you.
like to, yeah, with this, I would like to close this session. But Professor Ralston, do you want to say any closing remarks, anything before we wrap up the session?
Not really.
Any
Thank
tips
you.
for the students?
Well, thank you
Okay,
for organizing this. I've been delighted to do it. I know that I imagine that in India,
thank you,
as
sir.
in the UK, teaching is very difficult now, what with COVID, and we're doing everything online. And I just hope that that's been useful for everyone. And keep up with your studies. Don't forget about Davidson's, and hopefully some of us may meet again in person when I'm allowed to travel to India, which hopefully will be in the not too distant future.
Yes, we really hope to see you in India soon. So I would like to tell all the participants here that a recording of this session and the certificate of participation will be emailed to you in a few days. And we will soon be coming up with more such wonderful sessions from the other Davidson editors as well. So keep connected to our Facebook page of Elsevier India for the further updates. A copy of this Davidson Principles and Practice of Medicine is available on Amazon if you want to refer. Thank you, Dr. Ralston. Thank you very much for your time today. We
My
are really
pleasure.
honored to have you with us.
My
Thank
pleasure.
you.
Thank you. Bye bye.